Hello, I'm Norman Swan. Welcome to this programme on skin cancer. 2 out of 3 Australians will be diagnosed with skin cancer by the time they're 70. That's the highest incidence in the world, and it's vital to detect and treat skin cancer in its early stages, not to mention prevent it in the first place. So tonight we're going to discuss the prevention of skin cancer, risk factors, detection, diagnosis and evidence-based treatment. And we're going to focus primarily on the 3 most common types of skin cancer, certainly the most serious forms: basal cell carcinoma, squamous cell carcinoma and melanoma. As always, you'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. But let me introduce our panel to you. Jeff Keir is a general practitioner working full-time in primary care skin cancer practice. Welcome, Jeff.
Thank you.
Jeff's a clinical tutor for the International Dermatology postgraduate programs at the University of Cardiff and teaches for the North Coast GP training scheme. Ian McCall is a consultant dermatologist from Tugun in Queensland. Welcome, Ian.
Thanks, Norman.
His main interests are, well, one of his main interests are in online general practitioner education in skin diseases. Ian Olver is a medical oncologist and Chief Executive of the Cancer Council of Australia. Welcome, Ian.
Thank you.
Ian's clinical professor in the Department of Medicine at the University of Sydney. Jan Riley has specialised in dermatology nursing for a long time, Jan. We won't say since when. Welcome.
Thank you, Norman.
Jan has certificates in primary care, skin cancer medicine, advanced dermoscopy and dermal imaging through the University of Queensland. So welcome to you all. So Ian, truly the world's highest incidence here? We all talk about it. Was it true?
Yes, it is. We vie with New Zealand for that, and the sad figure is that 1,700 Australians die each year of skin cancer, 1,300 melanoma and 400 non-melanoma skin cancer. We have about 11,000 Australians being diagnosed with melanoma each year. And we're not quite sure of the number of non-melanoma because most of the cancer registries don't record them, but it's estimated at over 430,000, so it's a huge burden of disease.
And is the belief that it's commoner in rural and coastal areas true?
There are some areas around the coast. For example, in New South Wales, the north coast is higher than Sydney. The reasons for that are not immediately apparent, but yes, there certainly are higher melanomas reported in coastal areas.
It's commoner. The sun's closer up your area, isn't it?
Unfortunately, the correlation was thought that the closer you got to the equator, the higher the melanoma rates were going to be. But studies, particularly recent ones in Queensland, and also the raw data here from New South Wales, show that coastal and in that temperate band between about the Sunshine Coast and the Northern Rivers actually has a higher incidence of melanoma than either side of it. So it does seem that there are probably some lifestyle issues there with regards to pleasant temperatures year-round to be out in the sun as well.
Ian McCall, the risk factors are what we know, or are there some surprising ones?
For melanoma?
Well, melanoma, or, I mean, indeed, are they the same for melanoma and non-melanoma skin cancer?
No, they vary a bit. Certainly for squamous cell skin cancer, ultraviolet light is the major potentiating cause. Other factors come in, patients that are immunosuppressed and the like are very susceptible to get any type of skin cancer because your immune system is helping you all the time to stop skin cancers developing. But ultraviolet light certainly plays a part with melanoma as well. But everyone knows of patients who've got melanomas in places where the sun never reaches. And
what's the latest research on that, Ian Olver? The melanomas in places like the sole of your foot or your scalp?
Well, I think there's a combination of genetic factors as well as the environmental factors, and you need several hits usually on your genetic material to actually trigger off a cancer. So it's not just one cause or the other.
What about protective factors?
Well, I think the protective factors are things that organisations like cancer councils have been talking about for 30 years. It's the slip, slop, slap campaign, which was slip on a shirt, slop on some 30-plus sunscreen and put on a hat. And we added 2 more. That was the rather obvious one: seek shade during the hottest part of the day if you can, and slip on some sunglasses because your eyes need protection during the summer as well.
I think just something to add to that, though, is when we're giving sun avoidance and sun protection advice to people now, there's always a question about, well, what about my vitamin D? I've got to get some sun, haven't I? That's what I've been told. So, it's really, people are confused a little bit about that message.
Look, I think that's a very important question, and I think these sun protection messages in most of Australia are summertime messages when the sun is at its most intense. Certainly they don't apply at other times, but during the summer you probably only need a few minutes exposure to the equivalent of your face and arms during the day to generate vitamin D, and during the winter it's probably 2 to 3 hours a week.
What are the story, Ian McCall, about children's sunburn? Is it still true that your risk goes up the more sunburn episodes your child has had?
Yeah, it's probably one of the most important factors in assessing someone's risk of developing melanoma. The number of blistering sunburns that they've had, and it's been seen, throughout the world. It's not just in Australia.
Jeff, we've seen an explosion and somewhat controversially in some people's views of skin cancer, primary care skin cancer clinics. Have we improved the detection rate?
The data is actually not clear on that because the various states of Australia don't particularly differentiate between the levels and stages of non-melanoma skin cancer for a start, and also the level and stages of melanoma that they report. Certainly the figures we have for the Skin Cancer Audit and Research database, which is a very large database that's currently in investigation, is that for people who are motivated to find skin cancer early, we're finding a greater percentage of early melanoma than has been reported in literature before. So it's optimistic that if you're looking more carefully for it, you're going to find it at an early stage, but the full data's not completed yet.
Ian McCall, do you agree?
Yes, I do. I know about the SCARD database, and certainly, if you look at melanomas that are reported to the cancer societies, the cancer councils, I should say, then you find that, of the 70 per 100,000 here in Queensland, 50 are invasive, 20 are in situ. If you look at the SCARD database, in fact, there's 2 in situ melanomas being found to every 1 invasive. So these guys are finding these lesions earlier. The ones who are trained are certainly doing this.
So is there an argument for screening? Ian Over?
Well, there's an argument for screening, but I think the important thing is that people should know what their skin is like and report any change immediately. They shouldn't wait until another screening interval. But there's no data that actually proves the efficacy of screening, and probably won't be, so it'll have to be a common sense thing.
In terms of the natural history, Ian McCall, of these conditions, do we know what is a reasonable checking interval? I suppose it depends on your skin type and how many lesions you've got.
Very much so. It depends on your family history, your skin type. If you're Scottish with skin type 1 and you never tan and you always burn, then certainly if you've had a lot of
We Scots are invincible, Jimmy. What are you going on about?
But not here to the sun. There's an awful lot of Scots die from melanoma in Australia.
I think though with screening, I think we could encourage nurses particularly. We have people undressed for many reasons,
most of them
with health
legitimate
situations.
Yes.
So if you've got them undressed, then take the opportunity to look at their skin.
So encourage your practice nurses to become skin literate in a sense.
Opportunistic.
And
if they're undressed, look.
Easy to encourage patients if they've got the risk factors for it. And let's face it, if you've got a history of blistering skin, of sunburns in your childhood, if you've got a first-degree relative with melanoma, if you've had a previous skin cancer, if you've had exposure to things such as arsenicals and other chemicals on the farm, you're at increased risk. These people should be encouraged to self-present. And what we've certainly found is that when we're getting people to appropriately self-present for screening, they may not have a particular lesion of concern. We're finding an extremely high rate of skin cancers and melanoma in these people.
So let's go to our first case study. Who's Mary, 56 years old, fair skin. She swims a lot. She comes to see Jeff with a flat red lesion that's scaly and itchy on her upper back. Let's have a look at it.
Well, this is a fairly common presentation in general practice, and that's a pink, flat, scaly lesion, which could be any one of a number of things. You've got to sort of think of the things such as that are non-skin cancer, such as dermatitis. You've got to think of things such as psoriasis. You've then got to think of the skin cancer possibilities, which commonly in these areas would be intraepidermal carcinoma or Bowen's disease, or possibly even looking at superficial basal cell cancer, and the rarer things such as primary cutaneous lymphoma or mycosis fungoides and amelanoma.
So you're seriously scaring me now.
Well, it's a problem because all of these things are...
Because this could just be a piece of discoid eczema.
It could indeed just be a piece of discoid eczema, and there's two ways to approach it. You can approach it either empirically and say, look, I think it's discoid
Have a
eczema.
steroid and come back in 2 weeks.
Have a steroid and come back, exactly, but as long as you follow up the patient. Because you'll find that a number of lesions that don't respond to that, either you've got the diagnosis wrong and you're really having to look to biopsy it. But you can short-circuit that a little bit if you're actually skilled with the use of a dermoscope and dermoscopy. Sometimes you can actually make a fairly confident and firm diagnosis of what it is using the dermoscope.
So you two have brought a show and tell here with dermoscopes. Show me what you're talking about here.
Well, there's a number of these simple little handheld magnifiers, and this is called a Heine Delta 20, and the Heine Delta 20 is a non-polarising dermoscope that requires contact with the skin, and what it does is shine a bright light and you can examine the skin under magnification.
And do you need oil or water?
It's best to have a contact media, such as you can use 70% alcohol, isopropyl alcohol, or you can use oil. But the alcohol is much easier to use, it's simple to evaporate off the patient. Or you can use a non-contact method. These are polarised dermoscopes, simple little items called the derm light. And with these ones, you don't even have to touch the skin to get an image. It uses polarised light to reduce reflection. You can see a lot more detail. And some of them are even able to be attached to cameras. And for example, this is an old Coolpix, and there's quite a few adapters that can be used, and you can actually attach that then to your camera and take a photograph of the image in question and put it in the patient record. Quite easy to do with Medical Director or any other medical software programs.
And what's that you've got, Ian McCall?
Well, it's just another type of dermatoscope. This one is a dermite fluid. It's a non-polarizing one. The thing about polarizing light penetrates deeper into the skin, so you can see deeper structures with it, but you sometimes miss little miliarid cysts that you see in the surface of seborrheic keratosis, which is a common pigmented lesion that's benign. And you don't see blue structures, melanin deeper in the skin as well with polarizing dermatoscope spot.
So you might want to use both.
You might want. It's good if you. There's a new one out called a DL3 that has both a polarizing and a non-polarizing. You can just switch between the two, and it's a very good dermatoscope, and it easily connects, as Jeff shows, to cameras, because taking photography is an important thing.
Jan, you've been trained in this. I mean, how difficult is it to use? I mean, a lot of GPs think, oh, gosh, I'm not quite sure what I'm looking at even with the naked eye, and then I'm going to actually compound the difficulty by magnifying it. God knows what I'm looking at.
They're not difficult to use, but getting your eye in, making sure that you practice enough and correlate what you see and what you believe a lesion to be, and if you go on and biopsy it, you know, and gain sort of proof of your accuracy or not, is quite important. Otherwise, you know, I mean, you don't get your skill up. So you have to work at it.
Ian McCall?
Look, I'd agree. I think ongoing learning, taking the opportunity to look at everything that you can in fact put your dermatoscope on is very good. And at first you...
So you're going to over-biopsy poor patients or what?
Not necessarily at first. Certainly if you look at when dermatoscopes are introduced, some people do over-biopsy at first. They get alarmed at first. But as they learn, just by reconciling what the results are from their biopsies, they biopsy less and they become much more selective at in fact picking up early melanomas and in using it in other non-melanoma to skin cancer as well.
Jeff, and if you're a rural GP and you can't get locums to go off on courses, are there other ways of learning?
There are online resources. Some of them are actually free. For example, there are short courses online for the International Dermoscopy Society, IDS.org. There's also DermNet New Zealand. They also have them. The Skin Cancer College of Australia and New Zealand have also courses which people can participate online, and Learn Dermatology as well has various resources for these kind of for this kind of training. So but it is important to get some level of training, either at the very least over the internet, and because it's a very, very visual field, and if you're able to attend one of the courses, that'll reinforce what you've learned online.
So let's look at what Mary's lesion looks like under the dermoscope.
So here you can see a totally different view. All that reflection from the scale is gone. You've used some liquid on the dermoscope, and you can actually now look at the structure of this lesion within the epidermis and the dermis. And what you can see are some classical features of superficial basal cell cancer. And there are some brown browny grey globules of colour or blobs of colour there, and that's commonly seen in basal cell carcinoma. There's also these white lines which are highly refringent and reflective with polarised light, crisscrossing the background, almost making it look like mother of pearl. You've also got some tiny ulcerations. What you can't see here is other typical features of basal cell cancer. It's very, very finely focused blood vessels, but there's enough features there to make a firm diagnosis that this is going to be a superficial.
But certainly not dealing
cancer.
with a piece of eczema.
You're not dealing with eczema, you're not dealing with psoriasis, you're not dealing with intraepidermal carcinoma or Bowen's disease. You're dealing with basal cell cancer here.
So, Ian, what would you do about it here? Do you need to biopsy if it's so obvious on...
Depends how experienced you are. That's quite a big BCC, and it's an unusual superficial BCC because of the amount of scale there. The larger BCCs are like that. The longer they've been around, the more that there may be an infiltrative component within this. And if you're thinking of using topical therapies to treat this, then you don't want to do it if there's an infiltrative component. You only want to do it if it's a superficial BCC that these topical therapies will deal with. So a biopsy is not a bad idea. In a big lesion like that, you probably should take 2 or 3 little punch biopsies to make sure that it's a uniform histology before you do your treatment.
So in fact, there's a question from a general practitioner in Queensland asking, is there a minimum punch biopsy size and should you suture a punch biopsy?
Well, the pathologist won't thank you if you give them a 2 millimetre punch biopsy. It's too small a bit of tissue. A 3 millimetre, I think, is the minimum. And I usually do suture a punch biopsy, especially if it's going to be in the leg. So you'll just have a trail of blood along the carpet when the patient's walking out, unless you put a big plug over it and tape it on. So yes, 3 millimetre should be your minimum punch biopsy size.
On a practical basis, sometimes for these superficial lesions, if you're countenancing, treating them with curettage and cautery, just be aware that a punch biopsy goes through to the deeper layers of the skin and you can actually get your curette caught. So sometimes it's even worthwhile doing a shave biopsies which don't go through that full thickness. So you actually preserve some of your treatment alternatives for these lesions.
How important is the history, Jan, in terms of diagnosis or understanding what might be wrong with Mary? The history of the lesion?
Well, the history is going to give you an idea of whether you're going for something like eczema or psoriasis, or whether this is more specifically a sun lesion if it's an isolated lesion. It's really quite important for an overall view of the person. I mean, a lesion is on the person. It's not something that's standalone. So you need a view of what's going on with that person.
Solitary lesions, it's unusual to get a solitary lesion of eczema or a solitary lesion of psoriasis. There's usually multiple lesions. So when you get a solitary lesion, skin cancer should spring to mind straight away. And
let's go back to the picture of the dermoscopy here of Mary. Where would you biopsy it?
Generally in a BCC like that, it really doesn't matter. You might avoid an area that looks as if it's been scarred, because you may just, remember, your immune system's reacting all the time to skin cancers. It's trying to get rid of things as well, and sometimes you'll get bits of regression, you'll get bits of scarring. So if you go for a white area there that's scarring, you may just get scarring in your report.
And of course, Jeff, you can get pigmented BCCs.
Yes, they're actually quite common and they're actually very beautiful under the dermoscope. It's a pity we don't have any images tonight. But they're quite common, and again, the features of those, if you put a dermoscope on them, are not dissimilar to what we're seeing here. You've got areas of ulceration, you'll have much, much larger pigment globules, and you'll have finely focused blood vessels across the tumour. And we'll see some of those examples, I think, later tonight.
So, Ian McCall, what are the treatment options here?
For a superficial BCC like this, you've got topical therapies.
Well, as it turns out.
Yes. You've got topical therapies that you can in fact use, and the major topical therapies for that would be imiquimod or Aldara, a topical therapy that enhances the body's immune attack to these tumour cells. Or there's another therapy called PDT therapy, photodynamic therapy, where a cream is used that's selectively taken up, photosensitizing cream, which is selectively taken up by the tumour cells.
We'll come back to that later.
Yeah, and then they can get treated with that. Efudex I don't usually use for superficial BCCs, I'll use it for superficial SCCs. You can excise a lesion, obviously, you can curette a lesion, as Jeff said, as well.
When it's a BCC we're talking about.
Sure.
But we'll come back to whether that works later. And what about Mohs surgery?
Well, Mohs surgery is reserved for those basal cell skin cancers that are less well defined, that are infiltrating BCCs, where you can't determine the edge. You may think the edge is at a certain point, but in fact there's little spicules going out, and it extends out a lot further than you think. And often the margins of excision have to be between 5 and 7 millimeters. And most surgeries, particularly used where you've got sensitive areas around the nose, around the eyes, where you're trying to conserve tissue and make sure you're taking out all the tumour, but not taking out more tissue than you need to, because it makes the repair much easier.
Let's go on to our next case study. Robert, who's 34, he's got a family history of BCC, and he noticed a lesion on his nose, and it's bled once or twice in the last 6 months, but he's not sure how long it's been there and doesn't have any other symptoms. Let's have a look. God, you'd easily miss that one, Jeff.
It's one of these small lesions that you can easily miss, and certainly with the naked eye and clinical examination over the years, I've missed plenty of them. But again, it's one of these things that show the utility of looking closer with a dermoscope. And again, these small BCCs, even though they're very small, do show classic features, and in particular, and I've said this before, finely focused, often branching or serpentine blood vessels across the lesion, and they'll often look pink and structurous, and if you look at them under magnification, often almost have a jelly-like quality to what you're looking at. And this shows quite clearly in this image.
This is a dermoscope.
This is the dermoscope view, and this is a magnified view of this very small lesion. It's only about 2 millimetres to 2.5 millimetres in diameter, but you can clearly make the diagnosis by looking at the centre. You see these finely focused, fine branching blood vessels. You can compare that to the thicker, less well-focused background blood vessels, and you can see the difference. There are some benign things that can look like this, but you're going to be pretty sure in this area it's going to be a BCC and not an ecrine poroma or something similar to that.
So what's the treatment here, Ian McCall?
Well, again, this is a well-defined, very small nodular BCC. You can take that out with narrow margins. I mean, we sometimes say BCCs have to be taken out with 4 millimetre margins, but obviously in the nose, and a well-defined one like this, 2 millimetres is fine. So you may only need to take that out with 3 little sutures to close the defect, and it's well within the province of any general practitioner to do that.
Do you want to comment, Jan?
No. I was just thinking if we were going to get onto topical treatments with, say, the superficial BCCs, just to backtrack for 2 seconds, is that a lot of those the patient response is very individual, and it's really important that people are supported in that care, but we might get onto that in a further case study.
And Jeff, once you've actually treated someone like this with a small lesion, how often do you follow them up?
Well, already they put themselves into the high risk category. They've got a previous history of non-melanoma skin cancer now. So at the very minimum, even if you're not following up this particular instance of care, they should have an annual skin check. But for this particular instance of care, it's worthwhile following up in 3 to 6 months to make sure there's clinical clearance. You can have a look at that either dermoscopically. If there's any suspicious areas, it's really worthwhile re-biopsying those.
Let's look at our next case study, who's Sue. She's 75 years old. She's the wife of a cattle farmer. She's always worked around the property. And she's got a lesion that's always irritated by her collar. What do you think should be done about it? Let's have a look. Jeff?
Well, you're having a quick glance at this one, and these type of lesions will often come in with a fairly indeterminate history. They don't know how long it's been there, it's only recently been irritating, and you look at it just on the clinical image and say, well, this is a little unusual. We've got a pink patch that's a suggestion of something pale around the outside. It's got very indeterminate margins, and you're going to think, well, I really want a closer look at this to decide what it is. It could be anything from a superficial skin irritation from a collar to something more significant. And again, this dermoscopy view shows quite clearly that we're going to be dealing with possible malignancy. You've got finely focused branching blood vessels, which immediately make you think of basal cell carcinoma. But the other thing you can't see, as opposed to the previous ones we've seen, there's no well demarcated edge. It's not fine and nodular. It looks a bit scar-like in the background. Those white shiny areas in the background is quite consistent with sheets of collagen, and which you see in these infiltrating BCCs.
How do you know this is infiltrating by looking at it?
By looking at this, you can, well, it's combined with the clinical view. The clinical view, you would look close, you would have found it would have been felt a little bit firmer if you ran your fingers across it. You wouldn't have seen a clear edge to it. And that is the pattern that you see with infiltrating BCCs. There's not much else that mimics this apart from scleroderma occasionally.
A bit harder to remove when you don't know where the edge is, Ian McCall.
Indeed it is. That's always the problem with infiltrating BCCs. And that's why you talked about Mohs surgery early on when you were doing this on the face, because it's a way of histologically determining where that edge is by doing serial excisions and examining it under frozen section at the time. And that's why it's an excellent technique for these infiltrating BCCs if they're on the face or other sensitive areas. But on
and of
an
course,
area
this sort
like
of area is bad for curettage as well because it doesn't have a firm base.
Well, you can't curette that. You need to have a firm dermis to curette. And anyway, an infiltrating BCCs has already got fibrous tissue. The cells are going between the collagen bundles. So, you can't feel the soft tumour tissue there. So you certainly wouldn't try and curette. If you had biopsied something that was an infiltrating BCC, you don't try and curette them.
So this one you excised, Ian?
Jeff, yes.
Jeff, sorry.
With these particular lesions, when you've got rural patients who often don't come into town very often, sometimes you've got to leap in and biopsy and treat all in one because you might not be able to get that patient back for some time. So this was an excision biopsy? This was indeed a very wide excision biopsy. The presumptive diagnosis was made dermoscopically. Normally, if I have time, I'd actually prefer to biopsy these to confirm the diagnosis. But unfortunately, I think we've got to be practical in rural areas.
And what sort of margin did you take here?
When you're looking at these, you really got to take 5 to 10 millimetre clinical margins to be sure that you'll
So quite a big margin.
Quite a big margin. But again, if you've got the minor surgical skills, and many of us in rural general practice do have these minor surgical skills, you can safely remove these in most areas of the body. Obviously, there'll be areas that you won't be comfortable and you will have to refer.
And she's got a fair scar.
She certainly has, it's a longish excision, but I think once you see that was able to be closed with just simple nylon suturing, and longer term, I think we have an image of about 6 months down the line, you actually can't see what's been done there. And crepey skin actually can do quite well, thank goodness.
And how often would you follow someone like this up?
I'd definitely follow this lady up 3, 6 and then 12 monthly thereafter, depending on her incidence of other skin cancers. And frequently we find that basal cell carcinomas occur almost in batches. In the first 2 to 3 years after them having one BCC, they will well have 1 or 2 or 3. And the more BCCs they have within that period, the closer your review times have to be.
It's just common sense.
Common sense, and there have been some good studies showing that. Doug Zarnicki did a great study earlier, in the 90s on this.
Let's go to our next picture, a little quiz slide. Jan, what do you think?
A very nastily sun-damaged hand, lots of hyperkeratosis, which is the thick, scaly, very spiky sort of areas on her skin. So she's got certainly some sunspots there, some actinic keratoses. And if any of those on examination sort of were painful or felt indurated, felt thickened under the skin, then perhaps some of those are turning into little squamous cell carcinomas as well.
Ian McCall?
Yeah, look, I agree. I mean, there's a lot of sun damage here.
This is a Scottish hand.
This may well be a Scottish hand. They've certainly had it out in the sun too much. But that thick hyperkeratotic area in the middle there, you'd be feeling the base of that. And it's, as Jan said, if it's infiltrated, if it feels thicker there, and if it's a bit painful when you're gently moving it from side to side, it almost certainly is an invasive SCC. It's not just a hypertrophic solar keratosis. So a hand like that, it's a very difficult condition to sort of, to deal with something where you've got such extensive damage. You often have to do it in stages, and you'd go for the ones that are with a thicker base and are indurated. You'd go for those first.
Ian Over, what's the difference in terms of natural history, cancer-wise, of these two tumours, SCCs and BCCs?
Well, very simply, BCC spends most of its natural history as local disease and causes its problem by locally infiltrating and spreading, whereas squamous cell cancer tends to spread earlier in the course of its disease, not only to local lymph nodes but to other organs such as the lungs. But the whole message is that these don't spread at all if you can get them early enough, and so the whole aim of treatment, not only to prevent the thing, but if you can't prevent it, is very early detection when they're surgically curable.
And how amenable to chemo or radiation are SCCs, particularly when they've spread?
Well, I think radiation is a local treatment, and it can be used in lesions in difficult places, or perhaps in older people where you want to avoid plastic surgical flaps and so on. Chemotherapy is really the last resort when either you can't do local therapy on a squamous cell, or local therapy has been done multiple times. And we wouldn't expect chemotherapy to cure the lesions. That's usually platinum-based therapy, and it can shrink disease down to relieve symptoms and buy another few months usually, but it's not curative therapy.
But compared to melanoma, it spreads later. It metastasizes
very
later.
much later usually than melanoma, which tends to spread early depending on how deeply it's invaded.
Which is why it's only 25% of the skin cancer deaths rather than more than that.
That's correct.
Let's go to our next case study, who's John, who's a 62-year-old Scottish migrant with the sort of skin that Ian McCall and I have been talking about. He takes about 3 or 4 beers a night. He smokes. He's an itinerant outdoor rural worker. He comes to see you, Jeff, with a white spot on the back of his hand. Let's have a look at it.
And this is a fairly common presentation. These patients will come along to you. I've got this scaly thing on my hand, and doc, it hurts every time I knock it, every time I put my hand in a pocket, which is of course unusual for a Scots. But these are common lesions that the patient will commonly present with, and they'll say, look, this hurts, doc, it's sore. And the other interesting thing about in the history we're talking about is the patient has a decent alcohol intake, and he also smokes, and both of these have also been shown to be risk factors for squamous cell cancer, as in fact a high-fat diet. So there's a couple of other things we didn't mention that perhaps people can change in their lifestyles to actually reduce their skin cancer risks. But anyway, this particular kind of thing, you put your hand on it and you squeeze it and the patient yelps. They're tender. The tumour started to invade. The body's got an inflammatory reaction against it. And in fact, most of that mounted pink area is actually not tumour. It's actually inflammatory reaction to the invading tumour. And management's very, very simple. It's too thick to freeze. You wouldn't curette thin, crepey skin here to get rid of it. It really needs to be surgically excised, and it's simple to do with 3 to 4 millimetre margins.
So an excision biopsy, basically?
A curative excisional biopsy, indeed.
Right, so you wouldn't try and biopsy it first?
No, there's no need for these small lesions.
And again, well, we'll come back to this in a moment. Actually, just a quick question. A GP from rural New South Wales asks Ian about the incidence of skin cancer in the Indigenous population and the problems of detection.
Often it's very uncommon to get melanoma in pigmented skin, but they can still get melanoma on their palms, the soles, inside the mouth, on the unpigmented areas. But of course they're more suited to the climate by having the pigment in their skin. And so you've got to be careful. They certainly can get it, but it's very uncommon.
A question from rural South Australia, Ian McCall. Should you use if you're going to be using a dermatoscope, should you dermatoscope every skin lesion you see?
Look, that can be awfully difficult if you've got someone coming in with, literally hundreds of moles. What tends to happen is you scan someone, you look for a lesion that's lonely, that's on its own, there's no other similar ones round about. Or you look for what we call the ugly duckling, the one that stands out, that's different from the other nevi out there, and you tend to look at those. You can actually scan nevi with a dermatoscope really very quickly, the non-contact ones. So you'll get used to examining 20 to 30 of those patients
pretty quickly.
Very quickly.
So Ian McCall, what kind of different kinds of squamous cell carcinoma are there?
Some people will argue that even a solar keratosis is a squamous cell skin cancer. It's an incipient squamous cell skin cancer. But then you have the SCC in situ, or Bowen's disease, where your skin cancer is just in the epidermis itself. The abnormal keratinocytes are there. There's nothing through the basement membrane. It hasn't invaded into where the blood vessels and lymphatics are. But then you get your invasive SCC when it goes through the basement membrane. And histologically, they're defined as being well differentiated, moderately differentiated, and poorly differentiated. Most of the ones that arise from pre-existing solar keratoses are well differentiated, have a low risk actually of spreading elsewhere, and can be taken out with 2 to 3 millimetre margins.
Whereas so this comes back to the history again?
Not part of the history, where they've come from in the beginning. If you've got something that's slowly arisen and they've got a lot of solar keratoses there, then it's likely to be well differentiated. If you've got a lesion that's arisen very quickly and you've suddenly got a big ulcerated lesion that's there and it's grown in 2 months, then that ain't going to be a well differentiated SCC. That's going to be poorly differentiated and a potential problem.
And What about when people use the word actinic? What do they actually mean?
Sun-induced.
So it's just another word for solar.
Yeah.
Ultraviolet induced. I mean, you could say, solariums are actinic as well, and PUVA treatment is actinic as well.
Yes, indeed, they are. And solarium, certainly, we've got the message across that it's not a good idea to go to solaria to get a tan.
Now, John moves moves from community to community, and 4 years later he presents to another GP with a non-healing ulcerative lesion on his lip, and he's got palpable submental lymph nodes. Let's have a look. Jeff, you're the other GP.
I see.
Could the other GP have missed this? I mean, 4 years ago, would he have been likely to have had the premonitory, the early lesion on his lip?
It's a good question. I mean, SCCs can grow extremely quickly, and it's quite likely there was nothing like this, 3-4 months ago at all. It is possible, however, to have a fairly long prodrome of leukoplakia, which is really, actinic cheilitis, which is solar keratosis or actinic keratosis of the lip. But quite frequently, these things can erupt quite quickly, and these are things that patients usually present to a little bit earlier than this poor chap has.
And Ian McCall, what's the treatment here?
Well, this is a big lesion in the lip. Initially, you'd biopsy this. I mean, it's almost certainly a punch biopsy. It's going to come back as a poorly differentiated SCC, especially if he's already got submental lymph glands. This isn't something that you can handle in country practice. This really needs referral to a tertiary centre because he'll need probably a big wedge, half of his lip getting taken out there for that to be removed, plus the lymph nodes will need to be removed, and may need radiotherapy to the band, and there may well even be perineural spread with this. It can go via nerve as well and can spread well beyond the areas of the excision. So this isn't one that you'd deal with in country
it's in the
practice.
danger areas. I mean, SCCs that are moderately to poorly differentiated on the scalp, ears, lip, nose can do very, very poorly indeed.
And as you said, Ian, over earlier, systemic therapy may have some role, but you can't hold out much hope.
Yeah, I think it particularly has a role if this became symptomatic, if it was failed to be controlled with the local therapies of surgery and radiotherapy.
Let's go to our next picture. Jan?
Okay, a nice scaly plaque.
I like the way all you people who are involved in just skin call them nice.
Well, I mean, I guess I'm imagining myself feeling it. It would feel.
Yum, yum, yum.
It would have a firmness to it. It's not going to be soft. It's going to feel a little bit indurated and a little bit tender, and that's probably Bowen's disease, intraepidermal carcinoma. Yes.
So this is carcinoma in situ, Jeff?
That's right. So it's squamous cell carcinoma right in the epidermis, and as Jan has intimated, they often look very, very bright red indeed, but some of the scaly ones have that redness masked somewhat.
And diagnosis? Apart from visual? What, are you going to take a punch biopsy here, or what are you going to do?
It's certainly worthwhile taking a punch biopsy of this to make sure you don't have any invasive component. It's a difficult area to treat surgically, and if it's one of these ones that can be treated with topical therapies, and you can prove that by a reasonable biopsy, then it's worthwhile trying to preserve the skin and function of the hand there.
And you could proceed to that topical therapy in general practice without a referral to a dermatologist, do you think?
Certainly with using treatments such as 5-FU or Efudix, absolutely. That's something that's well within the realms of general practice.
Ian McCall?
Yeah, I'd agree with that. The areas where you've got to watch SCC in situ like this is if it's near hair-bearing areas, because it does go down the hair follicle as well, and sometimes you won't get the bits further down. Later on it will recur growing up out the hair follicles, little red spots within the scarred area, where you've in fact treated it.
But difficult to remove in a position like this.
Oh, look, it is. It's difficult to treat there. Efudix can be used. Aldara, imiquimod can also be used, although in Australia it's recommended mainly for superficial BCCs, but it actually works very well for SCC in situ as well. And we mentioned photodynamic therapy.
So let's just see, we've got a picture here, a couple of pictures down the track, but let's go to it straight now. We've got a photograph of photodynamic therapy. Just explain again what it is.
Well, photodynamic therapy is where you use a photosensitizing cream. It's usually methyl aminolivulinic acid, Metvix, and you apply it over the offending lesion, occlude it, send the patient away for 3 to 4 hours. In that time, the tumor cells, surface tumor cells, take up the photosensitizing chemical much better than the surrounding skin. They come back after 4 hours, wipe it off, and you shine a red light on it, which actually activates the photosensitizing chemical that's now been taken up by the tumor cells, and it's delivered over a period of about 9 minutes. And then the tumor cells basically just die and peels off as a scab. It can be. It can look very good at first, but like everything, initial looks can be deceiving, because the problem is that the success rate further down the track, 2 to 3 years out, is somewhere between 75 and 80%. So there's perhaps 25%, in fact, it doesn't really cure.
So Jan, follow-up's important?
Absolutely. Support during that sort of treatment is important, but certainly follow-up as well. And I think it's probably one of the important areas where nurses can support people in understanding why they need their follow-up, and that they do need to come back, because it's in discussion with nurses perhaps where the patient will really sound it out as to, is this important, and is the doctor really, overemphasising this to no real
Let's flick through just 2 or 3 quickly, 2 or 3 quick shots of SCC. Jeff, just talk us through them, just so that people at home, or viewers, can actually get a sense of the spectrum here.
Well, what we're looking at here again is a scaling lesion, and just like the first one we saw tonight, your question is it going to be a little patch of dermatitis or tinea or psoriasis? But you've got multiple ones scattered around. You've got to perhaps even think of psoriasis, and if you're uncertain, biopsy at least 1 or 2 of them before you start treatment. If you're going to try any non-ablative therapies, you really need to get a biopsy proof first of these lesions, and these ones can do quite well if they're on a firm base with curettage. They can do quite well with Effudix. On drier skin with Effudix, trick sometimes you need to do is apply the Effudix under occlusion twice a day for a slightly longer period.
So this is somebody obviously with you may call older skin, more difficult to treat, of diffuse, diffuse
This
nature.
is, as Jeff said, in the lower legs like this, it can be very difficult to curette these. Elderly people, thin skin, on anticoagulants, a lot of sun damage. You try and curette that, and you'll be down into the fat layer before you know what's happening, because there isn't any firm base underneath. So you just end up with an ulcer. This was a lady who's got a giant SCC in situ. It was initially treated as a fungal infection. She was a patient with severe rheumatoid on methotrexate. So her immune system was affected as well by that, and they didn't pick this as a superficial SCC. And it's now covering about almost up to half of her lower leg.
How did you treat that?
It's awfully difficult. Radiotherapy would probably be about the only treatment you could do. We did try PDT, we tried some Effudix as well, but she's an elderly lady in her 70s, very thin, confined to a wheelchair with her rheumatoid arthritis, and the dear lady in the end said, no, look, I'll quietly just live with this. We keep watching it. If there's any bit that thickens, it looks as if it's an invasive SCC, we do a little excision on that.
And just the last one now, Jeff?
Again, very similar to the previous ones, almost isolated lesion.
Hard to tell apart from a BCC.
It is. Again, this is where the dermoscope can indeed help you. If I applied a dermoscope to this, we'd most likely see that we're going to have multiple coiled, or what used to be called glomerular vessels, little roundish glomerular-like vessels you look under magnification.
Sort of curled.
All curled up in a nice tight little ball, and you'll find them
nice again.
Of varying sizes within the lesion. Again, it's worthwhile biopsying initially to be sure before you do start treatment. But Ian made the point with this lady on methotrexate. These are becoming patients who are on immunosuppressants for various autoimmune diseases, and patients also with chronic myelodysplasias, chronic lymphoma, are an increasingly large group of patients in our practices, in general practice and in skin cancer clinics, and they do deserve special attention because they're at high risk of widespread multiple lesions.
How much attention, does the skin get in oncology clinics when you're not treating the skin but you're treating other things that might induce skin cancers?
Well, I think it doesn't perhaps get as much as it should, because you're often dealing with metastatic disease in a medical oncology clinic, and the skin lesion in the context of widely spread other cancers may not get the attention it deserves. However, the same things apply to any examination. You should try and examine the patients thoroughly by exposing the area, taking their shirt off and examining them in their underwear, which is very useful for all sorts of cancers, but gives you a chance of identifying a skin lesion. And these patients are often immunosuppressed on chemotherapy or other treatments.
And I suppose it's another message for GPs who have patients on cancer treatment that keep an eye on the skin.
I think they've got to be particularly careful and not allow a skin lesion to, or not watch it for too long if they're worried about it.
Let's move on, go to our next case study, who's Joe, 68, a retired labourer, and he's got an isolated lesion in his upper arm. He didn't notice it himself. Jeff found it on skin examination. Let's have a look at it.
And this is a lesion that stands out clinically and it attracts your eye. It's a very lonely lesion. There's nothing else quite like it on his arm. It's also typical of a lot of things that we see once you start undressing your patients and having a look at them. But 50% of the melanomas we find are on the trunk and under clothing. And if you don't at least get the shirt off, you're going to miss those, as he would have missed this. And if we look at it even closer with the naked eye, this is a macro shot, so as it would look if you're looking at it quite closely. And already we're starting to see some clues, and the clinical clues that are used for melanoma are the A, B, C, D, E, which is asymmetry, border irregularity, multiple colours, a diameter of greater than 6 millimetres, and perhaps a history of E for evolution. And we can see that this is probably consistent with that.
So the person, well, if they knew that it was there, they would tell you that it's changed.
They may well do, indeed. Or if you've noticed it earlier and you're monitoring it as well. Now, if you look at it even closer again with the dermoscope, you can be pretty sure that you're dealing now with the melanoma. What we've got a lesion is quite obviously it's chaotic. It's asymmetric in colour, it's asymmetric in pattern. And it does actually have some of the several clues that you can find.
So why don't you run through the clues?
Well, there's a whole list of them, and they're not totally agreed upon, but in this particular lesion, for example, we've got this asymmetric area where you've got loss of structure. It's pale and structureless, and you've also got some blue-grey structureless areas. You've got some brown dots which are irregularly distributed on the lesion. It's a bit harder to see at this magnification, but there's also some thicker network. We can also see in melanomas, we often see grey areas of any type. They can be an alarm button for you to press. Black dots and blobs around the edges of a lesion like this can make you think it's a melanoma. Lines streaking away, brown lines streaking away at the edge of a lesion, what we call radial streaming, can be a clue. Blood vessels that have different patterns, we call polymorphous vessels, are a clue. And also white lines, which look almost like a negative network. They're a white mesh pattern instead of the brown mesh pattern we normally see in a mole.
And how's that different from, say, a junctional nevus?
Well, junctional nevi, when you look at them with dermoscopy, are usually a single colour, a single pattern, and because the melanocytes at the derma-epidermal junction, they're flat, they're impalpable, they've got no raised areas there, and you'll see that the network of these particular nevi fade out into the surrounding skin rather than have an abrupt cut-off like a lentigo. If we're then looking at something that is more towards possibly being a melanoma, and not everything that's irregular is a melanoma, but you better have your antenna up and think about biopsying it. It's going to have irregularities in its structure, such as we've detailed in that little list there.
So how do you diagnose this?
This was obviously made a diagnosis clinically. There was a suspect lesion with those features, and according to the guidelines that are published now in Australia and New Zealand for melanoma management, this was excised with a 2 millimetre margin as an excisional biopsy. It's important to get all the lesion because the edges of the lesion often give clues to the histopathologist as to whether the lesion is circumscribed or not. That's one of the features they look for. And once you actually have that information from the excisional biopsy, they'll tell you what its Breslow thickness is. Now, the Breslow thickness is the thickness from the stratum, the granular layer of the skin, down to the deepest level of the actual melanoma. And from that information, you'll know what kind of margins this needs or whether you need to refer the lesion.
So it came back as a Breslow 0.2?
It did indeed. So it's quite a thin melanoma. Less than 1 millimetre is considered a thin melanoma. And the guidelines state that you're wanting to have your excision margins for in situ melanomas, 5 millimetre clinical margins need to be done down to the fat underneath. If you're looking at up to 1 millimetre...
Just down to the fat?
Just down to the fat underneath. Some people will argue to the deep fascia, but for in situ lesions that really is not necessary. If you're looking then at a lesion that's invasive up to 1 millimetre in depth, then you need to go a little bit wider. You're looking at 10 millimetre margins and down to the deep fascia, or at least a centimetre, probably whichever comes first there.
Ian Over, there's the story around, a common story, you know, surgery can induce cancer worsening. And could an excision biopsy actually provoke metastatic spread or you know, more aggression?
No, this has always been a theory that could potentially happen, but we've never actually seen it. There is no evidence that this would occur. So in this situation, if you follow the guidelines and do an excision biopsy and then later on, according to the depth, deal with the margins, you can be sure that you're not going to exacerbate the cancer.
So what about the role? People are saying more and more you should do a sentinel node biopsy with melanoma, just as you increasingly are doing with breast cancer, just to see whether there's lymphatic spread.
Well, this is a controversial area. It clearly depends on the whole situation of the patient, and there are some people arguing for it and against it. A lot of the trials that did sentinel node biopsies were looking at prognosis. They were looking at it to choose the arm of the study to go in, and I think we're in a period now where people are trying to determine when to do a sentinel node biopsy. In a very severe melanoma, a very deep melanoma that's likely to spread with a high possibility, that the sentinel node biopsy isn't going to help at all. So I think we've got to refine, because we don't have enough evidence to tell us precisely when to do them.
So this is doing melanoma surgeons out of business. I mean, the GP can handle this quite well in a rural town.
A GP can handle this perfectly adequately. Let me go back to the beginning, though. The important thing not to do here is to do a punch biopsy on this. The important thing is to do the excisional biopsy. Punch biopsies can be very misrepresentative of the underlying nature of a melanocytic lesion if they're not chosen correctly. And a lot of mistakes have been made that way in punch biopsy and getting a report back that's relatively benign and leaving it, and it's a melanoma. So they have to be excisional biopsies. And this one, a 0.2 millimetre thick melanoma, no one's going to do sentinel lymph node. The chances of that being anywhere near a sentinel lymph node are exceedingly small. So there's no need to do that. It's only when a lesion's 1 millimetre or thicker that you would really consider at least discussing the issue of sentinel lymph node and referring the patient. If the sentinel lymph node is negative, then certainly the patient's prognosis is better. And that reassures a lot of patients. The unfortunate thing is if the sentinel lymph node is positive, then most surgeons, the conventional treatment now is to then go and cut out all the rest of the lymph nodes. And there's no evidence that that actually improves a patient's prognosis at all. There's none at all.
Lymphedema to be concerned
and they
about,
get all the complications. So it's this following step, knowing the prognosis aspect's good, but going that step further and having all the glands taken out is the really contentious thing that there's no good evidence for.
And what about adjuvant therapy in melanoma?
Well, we're at a stage now where there's no recognised adjuvant therapy in melanoma outside a clinical trial. For a while, interferon was looked at, but subsequent trials suggested that that wasn't actually improving the outcome. So we don't offer adjuvant therapy, and I think one of the difficulties is up until very recently we haven't had much promise in therapy of widespread disease, so we've really had nothing that gives us any encouragement to use in the adjuvant situation.
And in widespread disease?
Well, in widespread disease, chemotherapy has been very disappointing. Dacarbazine's been the cornerstone of it for years, barely a 15% response rate with little influence on survival. But just recently we've started to see some targeted therapies come through. One is targeted at a mutation in the BRAF gene that up to about 50% of melanomas have, and we're starting to see response rates in some small studies of about 70%. Now, we still need to know how durable they will be.
With extended survival?
Well, it's extended survival, but we can't suggest that that's anywhere near cure yet, because they're not achieving as many complete responses as you like, and they're getting some rather odd side effects. The strangest one, about a quarter of them are getting squamous cell cancers of the skin. So that's a strange one. And there's another antibody, CTLA4 antibody, that's directed against an antigen on a T lymphocyte that's actually stopping the immune system from doing its job on the melanoma. So if you can block it, maybe the immune system can take over. And although that's got a smaller response rate, that's where we're beginning to see some complete responses that are durable. So I think there's hope that in the next few years, with targeted therapies, we'll see an advance in the treatment of widespread disease, which I hope would subsequently then translate to adjuvant therapy.
What's the chances he'll develop a second melanoma, Jeff?
Chances are actually relatively high, and the studies are showing that a patient who's had a primary melanoma has a 5 to 10% chance at least of another melanoma in the following 4 to 5 years. So this is one of the main reasons for us to follow up these patients, is to detect their next primary melanoma.
So do you photograph them top to toe, do you?
It depends on the patient. Total body photography, which what you're referring to, is extremely useful for people with multiple nevi. So lots and lots of moles, some of which may or may not look abnormal, and you're having trouble tracking them, then it's worthwhile doing total body photography to look for new or changed moles. And remember, only about 20% of melanomas in patients with multiple moles will actually come from a pre-existing nevus. The rest will come out of the blue, which is why the total body photography can help you spot that new nevus for a closer look with the dermoscope. You can also image things dermoscopically serially. For patients who've just had the sun damage and they've got the isolated sun damage lesion there that's been removed, then total body photography is not really going to help because there's nothing to photograph.
Yes.
But the follow-up will pick up that next lesion.
Let's go to Frederick, who's age 73. He's an outdoor person, farms, fisherman. He's got a lower leg lesion, which he's noticed has bled from time to time. He just thought he'd knocked it in the paddock, but he came to see you, Jan, in your clinic because he couldn't get in to see the doctor. He's got a 3-month waiting list. Let's have a look.
Well, a nice, no, I won't say that. It's a red lump.
It's pretty yucky to be honest.
Yes, but it's elevated and it's firm and it may well be growing. A lesion like that, I would consider it suspicious.
Of what?
Well, I guess I know the slide, but it's for amelanotic melanoma. So it would have it would be demonstrating a rapid growth rate, I would imagine.
Jeff?
Well, absolutely. I mean, this is what I call in Latin a lumpus pincus, and there's a fairly wide range of things it could be. Most of them are quite nasty, and amelanotic melanoma is top of the list. And thick melanomas, nodular melanomas, are killers of elderly people, and quite often they present like this. The other things that can look like this that can also be nasty are things such as Merkel cell carcinoma or atypical fibroxanthoma and poorly differentiated squamous cell cancers. So if you're seeing a pink growing lump and you're not sure that it's clearly benign, you've got to remove it.
So, Ian McCall, an excision biopsy here.
Yeah, an excision biopsy. You know, we've talked about ABCD and then EFG, elevated, firm and growing. And certainly all these conditions that Jeff's mentioned, you really can't tell clinically, and you've got to do an excision biopsy.
So this is the
dermoscopic
view.
Yeah.
And it doesn't help at all. It's elevated firm. It's a clinical diagnosis.
So he had a Breslow's of 4 millimetres.
That's correct.
Thickness.
Yes.
So that's serious stuff.
It is serious stuff. His 5-year survival rate is probably 50-60% range with this, and we're keeping a close eye on him.
Right. Let's go to Brenda, who's 56. She presents with a lesion that's not responding to treatment for dermatitis. It's been treated over the last 6 or so months with antifungals and topical corticosteroids, but not getting any response. And she's come to see you, Jeff, because she's concerned. Let's have a look.
Again, this is another one of those isolated pink scaly patches that causes so much consternation, whether it's actually a patch of dermatitis or tinea, or is it a skin cancer. And this particular one was quite cryptic. It really wasn't clear clinically what it was, but it was certainly clear it wasn't responding to presumptive treatments that were given to it. And so again, your alarm bells should be ringing that this could be a skin cancer, anything from a superficial BCC or superficial squamous cell cancer to amelanotic melanoma. And in fact, this was biopsied to see which one of those it was. And
so we've got a close-up here of this one?
We have.
So this is the dermoscopy?
That's right, and you can see clues to the fact this was in fact a melanocytic lesion, and we've got what are called dot vessels. They're like the glomerular vessels, the little coiled vessels you see in intraepidermal carcinoma and psoriasis, but they're much smaller, so they look like dots, and also what we call linear irregular vessels. So it's got multiple
so the dots,
vessel
the clear
types.
things, or the dark things there?
The dots are the little dark red spots or little dark pink spots in the white there within that circle. They're the dotted vessels, and it's a subtle clue. I'll give you this is quite a subtle lesion.
To my eye, just doesn't look too different from that BCC we saw at the beginning.
And for all practical purposes, it doesn't matter. It's been identified that it's malignant, and the biopsy will then end up telling you
Except
exactly
that you
what
told me
kind
to do a
of
punch
malignancy.
biopsy in BCC, and I've just been told not to do a punch biopsy when you think it's melanoma. So what do I do, doctor?
Absolutely, and I think it's very, very difficult to be sure that this is going to be a melanoma if you're not very dermoscopically skilled, and these are subtle lesions, and these vessel types have only been recently described. So we certainly wouldn't expect everyone to pick that as a melanoma with a dermoscope without a bit of extra training. But clinically, you really should be thinking that it is a skin cancer, and you should be looking to biopsy it.
Right, but Ian,
Look, this is different though. This isn't a pigmented lesion. This is a non-pigmented lesion, and most times when you see a lesion like this and you biopsy, it's going to be a superficial BCC or it's going to be an SCC in situ.
So the trick would be to do several punch biopsies here.
Yes, but even just one in this is still likely to show you that it's it's not the BCC or SCC you were thinking. The pathologist will say, "Oh."
So what do you do if the pathologist comes back and says, "Well, didn't find anything," and you were really worried about it when you looked at it?
Generally, you'd rebiopsy it again, or you'd ask the pathologist to do some more cuts in it. Depends what sort of biopsy you send down. If you send a biggish bit of tissue, when a pathologist looks at specimens in a biggish bit, he may only be taking 3 or 4 cuts through it, bread loaf cuts through an area. So you ask him to do some more cuts and have a look further down.
So you trust your clinical judgment?
Oh yeah, you always back your clinical judgment against a pathologist any day.
Now we've got Darlene, who's 45 years old. She's a netballer, lives in a rural property. She didn't notice this lesion on her left arm, but Jeff did. Let's have a look at it. Jeff?
Again, this is one of those lesions which is not very impressive clinically on the long view. It is isolated, and it's one of these things that argues that you really should put your dermoscope on as many lesions as possible. But certainly to the naked eye, and from here, it doesn't fulfil many of the criteria of the A, B, C, D that we use to make us think of melanoma. If we look at it a little bit more closer up, on another image here.
So this is still the naked eye?
With the naked eye, that's right. What you can see is it is a little bit irregular, asymmetrical in border and pattern. It's not greater than 6 millimetres. And what is striking is you've got an area of pink in the middle of this brown lesion. So you really need to put a dermoscope on this and have a closer look and see whether you can convince yourself that this needs to come off.
Let's have a look.
And if we look at this, what we're seeing is a lesion that's around about.
Did it feel raised to the touch?
No, it was absolutely impalpable to touch. But if you looked at it, you can see that there's a lot of irregularity in the way that pigment's distributed in the lesion. It's all clumped into funny patterns around the edges. And on an even closer view, you're actually able to see some of the abnormal area where we've got no pigment at all. It looks a bit pinker with these what we call corkscrew vessels. Now, vessels, as you can gather, in skin lesions that have no colour in them, blood vessels are your only clue, and it's important when you do take up dermoscopy just to educate yourself about these. And so this particular lesion was considered as being suspicious for melanoma. It had atypical network, it had this structureless area which is a little bit eccentrically placed with the abnormal vessels. So it was taken out and sent along to the pathologist.
And what did they find?
And the pathologist's initial report was that this was a benign compound nevus, and which was really quite discordant with what we thought it was dermoscopically. And so because of the discordance, we called the pathologist and asked them to take more sections, and it was actually proven to be, on the further sections, a fairly obvious invasive melanoma, about 0.35 millimetre Breslow. Still early, still thin, but that could have gone through to the keeper. And what we find is extremely useful is for any pigmented lesion that you remove is to photograph it. It's useful for yourself, it's useful for your pathology reconciliations, and it's useful for your referrals if you have to refer a patient on.
Now, we've only got a couple of minutes left, but I think we can't leave the programme without talking about dysplastic nevi, where GPs feel the most nervous. Are they missing something or aren't they? Let's whiz through a few pictures and just talk to them as we go. Jeff?
Well, this gentleman has got multiple nevi, and these patients can be a real destroyer of your appointment schedule with the number of lesions that need to be looked at. And this patient's a great candidate for total body photography, of which this is an image. And you look at comparing this kind of picture for images down the line, perhaps a year later or 6 months later. And the patient can also do examinations with a partner, matching up the photograph they have in their hand with what the partner can see on their back.
Reinvigorate their relationship.
Indeed, if you put numbers against each particular...
So let's look at the... is this eye or is this dermoscopy? This is dermoscopy. So, you know, again, first sight, is this that different from a melanoma? What's going to tell you? I'm seeing clear bits in the middle. I'm seeing uneven pigmentation. I'd be getting the shivers down my spine that this is a melanoma.
Well, this is one of the problems with dysplastic or atypical nevi, that they do somewhat look like that. But the thing is, if one of them looked like that and all the other nevi were different, you know, looked benign, then you would go for this. But the problem here is a lot of them will look like this, but that's also a good sign, because they're not all melanomas.
Sure.
This is just a pattern that this particular patient has for the dermoscopy of their nevi. But it's sometimes, yeah, again, that's not too, you know, it's not too chaotic. But you'll get to a certain one later.
So it's got a smooth edge to it.
Again, there's you know, this particular one. It's within the pattern of the other nevi that this patient in fact had. But sometimes you'll come on one that is, you know, very, very chaotic in comparison to any of the others, or it has some of the dermatoscopic features of melanoma that Jeff was talking about. So
all these are dysplastic nevi?
Yeah, all of these are dysplastic nevi. The dermoscopy of them. This is another patient. Now, those are two big lesions that you'd certainly be concerned about. But the patient had said that these had been stable for years. They hadn't changed. You, in fact, photograph them, and the next time you see them back, you look at them again, and you keep looking at them. And just because these are very big lesions doesn't necessarily mean that they're melanomas. They're not. That was that particular patient there with these two big lesions on his on the side there. So photography is useful in following these up. But as Jeff said earlier on, the thing about dysplastic nevi is that often the melanoma doesn't arise from the dysplastic nevus. It's a new pigmented lesion that's come up. That's what you're looking for.
But in a patient who's had dysplastic nevi, so their skin is primed, if you like.
You're looking for both.
Yeah, I agree. You're looking for both.
So what are your take-home messages, Jan?
I think for good patient outcomes, it is that cultivate an educated, multidisciplinary team.
So get your nurse involved and have a friendly pathologist.
And keep the education up and keep it going.
Ian Oliver?
Well, my primary message is prevention. It's so simple to cover yourself up and use sunscreen during the summer. My other message, though, is get to know what your skin looks like, and anything that you're worried about that's changed, seek advice without delay.
Ian McCall?
The people who are dying are often the elderly males who have things arising on their back. So my take-home message would be to ask yourself, who's looking at my back?
Jeff?
In primary care, I'd say get yourself one of these, get your patient undressed down to their underwear, get some basic surgical skills, and you'll be able to take care of the bulk of the skin cancers that walk through your door.
Thank you very much to you all. Great programme. And I hope you've enjoyed it too. Our thanks to the Department of Health and Ageing for making it possible, and thanks to you for taking the time to attend and contribute. If you're interested in obtaining more information about the issues raised, there are a number of resources available on the Rural Health Education Foundation's website. That's rhef.com.au. Don't forget to complete and send in your evaluation forms to register for CPD points. I'm Norman Swan. I'll see you next time.